Hi there, my name is Kate Godley, and I'm a physician assistant at the Functional Medicine Center in Durham, North Carolina. And Dr. Salibi is our medical director and my supervising physician. And I just finished a master's degree in functional medicine and human nutrition from the University of Western States. Today we're going to be talking about mold, mycotoxins, and CIRS. So briefly, we are going to discuss the definition of what mycotoxins are and where do we find them, the symptoms of mold exposure and mycotoxin illness, as well as steps of treatment. The first step is actually to remove the patient from the source of the mold, give the VCS test, which we will talk about in detail, culture the patient's sinuses or nares, begin binders, order blood work and interpret blood work and hormones, as well as address the patient's diet, rule out other causes of their symptoms and allergies, begin treatment if needed with a compounded nasal spray, reassess the VCS test, send the patient information and coach them on something called dynamic neural retraining system, or a meditation program would be just as helpful, and then reassess blood work and reculture the sinuses. We also want to know what to do when the patient also has Lyme or one of the co-infections of Borrelia. And then what are some expectations and maybe some medical coding that will help you, as well as a case study. So the term mycotoxin indicates any sort of toxin that is made by a mold spore. So the tricky thing is that the toxins themselves are not living substances. I know that many of you here had microbiology courses and you grew fungus. And if you don't remember that, just think about the fungus that would grow on cheese or bread if you left it out, or if it was in the back of the refrigerator. And just think about what those spores look like. There are also, of course, types of fungus that are useful and healthy, such as specific mushrooms. But the saying is that the funguses or the fungi and the cockroaches will still be here till the end of time, right? So the funguses are very, very, very good at proliferating. They need a dark, damp environment. And unfortunately, in many states in our country, the laws often protect the landlords or the people owning the building. And so my personal experience with mold was that it was in our first building where my clinic was in Durham, and we had to move, and we did not, we actually had to pay our lease in full. So lots of legal battles and lots of issues because the laws often protect the landlord. And there's also a lot of providers who will not recognize mold as a valid medical diagnosis. But I'm here to tell you that mycotoxin illness is definitely a valid medical diagnosis. And I do believe it's the root cause of many of our cancers. As you can see, these toxins that are produced, I just gave two examples of two types of mold. The first one is Stachybotrys. The second one is Aspergillus, and these are ones that I actually see come up on testing, and I'll show you a sample mold test in just a moment. But the second one, Aspergillus, also produces aflatoxin as well as ochratoxin, and ochratoxin is the most common toxin found in our food. If you think about coffee beans, millet or flour, different types of grains are very prone to develop mold. And the problem is when we kill the mold spores, we do not kill the toxins because, again, the toxins are not alive. They're also very, very, very small in size. So they're all under 10 nanometers, but many toxins are under 5 nanometers. So this means it's also difficult to filter them out of the air in our homes. We have to look for filters that actually would absorb toxins that are smaller than 5 nanometers. And I just wanted to point out, this was actually an excerpt from the discussion of a paper on mice. And the authors of this paper, which the source is listed in the end, explain that exposure to lower doses, and they're actually talking about aspergillus here, but lower doses of the aflatoxin results in atrophy and apoptosis. And consecutive exposure is just as bad as an acute large exposure. And this is what we know of many, many toxins, right? Heavy metals and BPA and persistent organic pollutants, all of them, it's not a matter, for most people, it's not a matter of an acute exposure where you ingest a large amount of the toxin. It's actually the slow ingestion over time that actually gives us what's called our total body burden, right? So the authors of this study also noted acute neutrophilic rhinitis in these mice that were exposed to the toxin, elevated levels of TNF-alpha, interleukin-6, and IL-1, which are all pro-inflammatory cytokines. And then they found toxins and the increased cytokines in the adjacent olfactory bulb of the brain. So I just wanted to point that out because I think it's important to notice how close parts of the brain are to these sinuses that are infected and completely taken over by these toxins. So I included this slide to show you a sample air collection report from a local company here in Durham, North Carolina. And I like using this company to send to people's homes for mold inspection because they do not have any conflict of interest. They do not do the mold remediation. So all they do are inspections, and they don't have any financial reason to find mold or find harmful amounts of mold in the home. So I find them to be very honest and very thorough. They spend 5 to 8 hours in the person's home looking everywhere first before they set up the air samples. And they will not set up air samples if they don't have a high suspicion that there's mold there. So anyway, this person, if you look at the top, it shows you which room they've collected in. So this person on this slide had the outside front, living room, laundry, back bedroom, and kitchen and dining room done. And then on the left side, you actually see this first column on the left, you see all the names of the different types of mold and the families of mold that were tested for. In this specific case, the living room definitely had high counts of cladosporium. And at the bottom, you'll see total fungi counts. And they also include here dander and fibers and pollen. So you can also see if there's other reasons for the person to have allergy symptoms in their home, keeping in mind that dust often also carries mold toxins with it, which we'll get into a little bit later. And then here is the rest of the mold report from the same house and from the same client, and they've included the full bath, the master bedroom, and basement. And so when the patient came to me, she actually said she was concerned more about the basement, and then we discussed the master bathroom, because if you see here at the bottom, the total fungi count in the master bedroom is high, and my concern is that that's where she's sleeping, that's where she's spending a lot of her time. It's a little bit of a snowball effect. The more tired she feels, the more she sleeps, the more time she's spending in the bedroom, which I'm concerned has definitely too high of a count of cladosporium for someone who's sensitive to mold. And we will get into that and what that means later. So just a few terms to go over. A lot of times, Dr. Richie Schumacher will use the term water damaged building syndrome, WDBS, and he often he has quite a few papers that he has published on the subject of mycotoxin illness, and he will abbreviate WDBS in his papers. Damp building syndrome is also used when I now look in PubMed. Chronic inflammatory response syndrome is what I like to use with patients because I do think it does the best job of explaining to the patient, you have inflammation, it's been going on for a long time, we need to address it. When you're looking for ICD-10 codes to try to see if you can get things paid for, however, you often have to look for systemic inflammatory response syndrome. That is one that is an ICD-10 code. And mold growth in the home is another ICD-10 code, which is extremely useful to get cholesteramine, which we'll talk about in a moment, and other things paid for. And then mycotoxin illness is another way of also explaining it to the patient. But these all mean the same thing. So as you can see here, the symptoms of mold and mycotoxin exposure are many, and they are general symptoms that can also include many other diagnoses. I think what makes mold illness so difficult to diagnose and treat is that two patients living in the same home with the same type of mycotoxin exposure may present with completely different symptoms, and they often do. So you need to have a high index of suspicion for mold illness when someone presents with a lot of these symptoms. I would say ice pick pain, brain fog, hungover feeling every morning, severe fatigue, diagnosis of fibromyalgia or chronic pain. All of those are the things I see most commonly. I did see a patient who was complaining of headaches and a shaky feeling, almost like a low blood sugar, but we gave her a continuous glucose monitor and she was not actually having low blood sugar, so we ruled that out. And we did find mold in her home, and it was very interesting because of COVID. She was spending a lot more time in this home, out on the Outer Banks with her parents, who were in their early 50s, and her father had just been diagnosed with prostate cancer. And she really struggled to convince them that the mold in the home was what was making her sick. She was getting migraines. But once we started, first of all, we cultured her sinuses, which we'll talk about in a moment. And once we started binders, she felt so much better that there was really no arguing that it was the mold. So sometimes the treatment is the best way to confirm. Having said that, it was challenging for me because her father also wanted my opinion on how to treat his prostate cancer, which was very aggressive, which is very rare for someone that young. And I could not convince him that the mold might have triggered his cancer. But certainly I've seen that. I've also seen patients with severe insomnia, refractory to all medications, weight loss or weight gain. I've seen IBS, chronic diarrhea, or constipation with mold exposure. Again, the medications usually don't fix it. I've seen infertility that I do believe is linked to mold exposure, hormone imbalance, low testosterone in men, elevated testosterone in women. Certainly a lot of adrenal dysfunction that I think also started with persistent chronic mold exposure over time. Lots of interesting rashes with mold exposure. They don't usually look the same from patient to patient. Vaginal discharge that was just kind of a mystery. LabCorp couldn't tell me that it was any sort of infection. Neurological involvement, balance issues. These are the patients that try to come to my yoga class and they really have difficulty doing any sort of yoga because their balance is off. Again, thinking about how close the parts of the brain are to the parts of the sinuses that are filled with these mycotoxins. And if you think about how tiny some of these mycotoxins are, of course they're getting into the brain. And brain fog, which we'll go into more, this ice pick pain, which can come and go, and it doesn't usually last more than a few seconds. That's typically indicative of mycotoxin exposure. So the first and most important step involves removing the patient from the mycotoxin exposure. This is not as easy as it sounds. Sometimes patients are very attached to their belongings. And as the clinician, you know that they need to get rid of things in order to make them healthy. I even had a patient have to give up everything and just go live in a tent. She's actually now in Texas because she could not stay in North Carolina. She was so sensitive to mold. But any porous furniture, books, papers, clothing, equipment, you can scan documents that you need and shred them or get rid of them. But really the patient, if they're very sick, should not be doing this work because they're going to be exposed as they try to clean and clean out things. Also, many patients with mycotoxin exposure also have elevated histamines, which really is a separate issue that needs to be looked at. They may also be overreacting to grasses, overreacting to pollens, overreacting to wheat with an IgE reaction. You can certainly order IgE respiratory allergen panels in LabCorp. This is the IgE Area 2 panel. I do this on almost every patient that is showing signs of elevated histamines. And keep in mind that quercetin is a mast cell stabilizer, so it helps, but it's not preventative. It's only going to help it's not going to treat the issue right away. It's just going to help in the future is what I meant to say. Nettle and quercetin together can help. Things like DAO enzyme can help, which we'll get into in a moment. But often it starts as two issues. There's an allergy, but then there's also a toxicity problem. So in the office, I typically administer the VCS test. This is called the visual contrast test. It was originally developed for those in the Army or in the armed forces who were exposed to biological warfare, and they were able to pass the test once they had cleared the toxin from their system. So it works the same with mycotoxins. You will get a positive result of a mycotoxin exposure, which I'll show you on the next slide, if you have been exposed to mycotoxins. There's also a certain area of the test that tests for nutritional deficiencies, which I also find extremely useful. It helps me to identify those with Graves' disease, with celiac disease. It just increases my index of suspicion for malabsorption issues. You can take the VCS test at home. I've moved to giving it in the office just because a lot of times these patients are like our Lyme patients. They have so much brain fog that following multiple steps to calibrate their screen first is a little bit overwhelming. So we typically do this in person at the second visit now in the office. Just like with Lyme, in the second step, we have to open the detox pathways. There's all different ways to do this, and I know you're familiar with these. I like GI liver detox now by Pure Encapsulations. It's just a food-based product. Contains artichoke and brassica and different vegetables that are really helpful with detoxing the liver. Remember that if the liver's not working well, then it doesn't really matter what you do to the gut. So keeping in mind that those two go together. Address mitochondrial support, because oftentimes choline is depleted in these patients. They've used it up too quickly. You need to replenish phosphatidylcholine, and you need to also help support their B vitamins, their zinc, their iron, their copper, everything that the mitochondria would need to make ATP or make energy, which is a lot, you know. So mitochondrial support can involve food changes and supplement changes. Patients often grumble when we start to talk about mitochondrial support because it can end up being a lot of nutraceuticals every day, a lot of pills. But if they feel much, much better when they're taking these things, then it will support this idea and they will continue to take it until they feel better. Address gut health. Make sure that, you know, if they're eating gluten, dairy, soy, alcohol, caffeine, all of that needs to be eliminated or at least cut way back. Set expectations. We really need 1 to 2 years to get rid of the mycotoxins, especially if they're genetically susceptible. And then don't forget all of the tools of functional medicine, all of these pillars. If you've seen the functional medicine matrix, those things at the bottom, food, sleep, social connections, stress, and I like to say movement instead of exercise. Because of the adrenal dysfunction that we find in these patients, we don't want them to over-exercise, right? And we don't want them to exercise and then leave the sweat on their body and not immediately remove the sweat with a towel or with a shower, because the mycotoxins that are in the sweat, we want to get them out. And last thing I just wanted to say here is that the bile is often backed up. We often see sludge in the gallbladder of these patients. So keep in mind that secretagogues, things like Swedish bitters, as well as ox bile may come in handy for these patients. Okay, so here is a sample result of a visual contrast test that I gave to a patient the other day, and she failed the test. Now, the results say positive, but what that means is she's had a positive mycotoxin exposure. So it is important, if the patient's going to take this at home, that you explain a positive result means they need to download the PDF and send it to you and upload it to your EMR or however they need to get it to you. Columns C, D, and E are the ones that I pay the most attention to for the biotoxin score. The patient should have scored somewhere along the gray line, and she did not. Her results are that red line. So concerning, we definitely need to work on this. And then what we do is we give binders, and 2 to 3 months later we repeat the test and we see how she's doing. Again, you can give binders all day, but if they're being exposed to the mold again, the binders will not permanently help them feel better. They might feel better temporarily, but the consistent exposure is going to keep them sick. The next thing that I do in order in my clinic is number 3, I test for Marcons. Marcons is a specific type of coagulase negative staph, and this patient actually had a large amount, so that's that top where it says organism 1, and we use a lab called Microbiology DX, and if you'd like their contact information to begin to send them samples, I'd be happy to supply that at the end of the talk. And so the Marcons result here was positive. So what this says is, it basically tells you exactly what Marcons is, explains that Dr. Richie Schumacher has done a lot of investigation in this area. What are the biofilms and how can we get rid of them? And then which antibiotics is this patient sensitive to and which ones is she resistant to? So in her case, if I gave her Bactroban and the EDTA and the gentamicin spray, we should be good. She's resistant to erythromycin, methicillin, penicillin, and that kind of followed when you asked her what she'd been given for previous sinus infections. She'd been given these medications that are marked resistant, which makes sense, right? So avoiding anything that's resistant, and we are giving this in a nose spray. We are actually not giving this orally. It's very, very difficult for the blood flow containing the antibiotic when you take something orally to actually penetrate the sinuses. So be aware that this is going to be a nose spray. We want to get up to 2 sprays in each nostril 3 times a day, but I actually typically start people for the first 10 days just twice a day. They do sometimes have a little bit of bleeding, especially because of the EDTA, and so we don't want to make them panic. Some people also feel a little bit like the brain is detoxing, and we don't want that to go too fast and give them a headache. So go slow with the nose spray. When we compound it, I compound 3 months at a time so that it's not as expensive for the patient. Keep in mind that there are pharmacies that charge more for this and pharmacies that charge less, so ask your patient to call around or find one locally that you guys like. And then in addition, with the nose culture or the NAIRS culture, you will also get a fungal result. However, that previous patient, the fungal result was still pending. So the fungal result takes about 4 weeks, whereas you'll get the bacterial culture back much more quickly, right, which makes sense. You can prescribe the bag spray while you're waiting for the fungal result, or you can wait for the final result. It kind of depends on how ready the patient is for the first 2 steps. Are they ready to be removed from the exposure? Have they failed the VCS test, in which case go ahead and start treatment. Bag I just includes itraconazole. I've also seen patients that actually did not have any Marcons on their culture. They had a known mold exposure, and they only had resistant fungi once we grew out their culture. So I just gave them itraconazole. For the fungal infection, you can also add rifampin. This is something that Dr. Schumacher has published if you search PubMed. And again, remind the patient we really shouldn't be treating them until they've been removed from the source of the mold. So sometimes we have to pause this step, tell them to go figure out if they can move, if they can rent a new place, what they can do if the mold is in their home. Sometimes patients have to go out on disability if this is in their work. Colloidal silver is also an option. I have only had success with colloidal silver nose spray using the ACS 200, which is 200 parts per nanometer silver, so it's very concentrated. That I would not necessarily recommend at this time using the Argentin, the 23 parts per million. I do not think that is strong enough to fight something like Marcons. I haven't seen it work yet. Biocidin can be helpful to reduce biofilms. This is something I would give either in the throat spray or give the drops, as you all are probably familiar. Biocidin is a great catch-all for all different types of biofilms. The problem with biocidin that I want to remind you is that it does kill the beneficial gut flora. So this is not something that we should use for years and years and years, but there are patients that we need to build up their good gut flora, start the biocidin, remind them this is going to be 3 to 6 months and then we're going to take you off of this. But keep that in mind. Don't think that oregano and everything else in the biocidin is harmless, because it's not. In fact, garlic and green tea are really the only 2 herbals that do not kill the beneficial gut flora. I also like to add a Zelestine nose spray, especially at bedtime, for patients who also have elevated IgE levels. It's a prescription, but it works great, and it is not a steroid. Make sure you are not prescribing steroids for these patients. it's just not helpful when they have an infection in the nose to also give a steroid unless you absolutely have to. But I do use azelastine. Okay, so moving on to step 4 in the treatment of patients with mycotoxin illness. Cholesteramine, we often abbreviate as CSM. Wellcol is the brand name, and you can find a couple different generics out there. There's a fact sheet here where you can read more about cholesteramine. It does have the most research behind it for mycotoxins. However, it's not tolerated by all patients. It can cause severe constipation, which, to be honest, is the last thing we want in these patients. We are trying to detox them, keep them eliminating every day, right? We want the toxins to come out from the bile into the stool. We do not want toxins to be stuck in the patient and reabsorbed. If you think about how tiny these mycotoxins are, and if the person's constipated, they're going to be the first thing that would be reabsorbed from the colon. So not a good idea. You can try cholesteramine, increase the magnesium doses, and increase vitamin C. All of these patients require more magnesium and more vitamin C than the average patient anyway. A lot of these patients, as we'll talk about in the end, also have Epstein-Barr, cytomegalovirus, Coxsackie virus. They have a high vitamin C requirement, as well as the fact that the adrenal glands are not saving vitamin C. So I try to push these patients up to get 4 to 5 grams of vitamin C a day in the beginning and slowly increase from there. IV vitamin C is also great, but isn't really going to help with the constipation issue. For magnesium, let's try to get everybody on magnesium that is 5 times milligrams per day, that is 5 times their body weight, so in pounds. So if someone is 120 pounds, you want to give them 600 milligrams a day. And obviously that's not what most people are getting. Keep it in mind that we do get a little bit of magnesium from our food, from our diet. And we can also use Neuromag or magnesium L-threonate here. It's a great option, but it's not a high dose, so you just want to mix that in with all the different types of magnesium that are available. I really do think the magnesium is like the most important step in the detox. And then don't forget there's other binders. So if the person doesn't tolerate cholesteramine, or if it's prohibitively expensive for them, you can try GI Detox. It contains aloe, pectin, clay, and charcoal all in one capsule. I typically give this 3 capsules with at least 10 ounces of water twice a day in between meals. It needs to be 1 hour to 2 hours away from all supplements and all food. I've also seen activated charcoal alone work. It's great for people that are on a budget because activated charcoal is cheap. If you need someone to take something 3 times a day, you can also alternate different types of binders throughout the day, whereas the cholesteramine can be taken with food. Cytodetox, Zeolite, G-Pure, also very helpful. I tend to rotate binders and offer patient different options depending on the cost. Patients will gravitate towards the binder that is helping them the most. They will notice that their gut feels better, their energy levels better, and their brain fog gets better within 2 weeks of starting the binder. So in the last 6 months, I have moved away from ordering additional testing simply because patients are already overwhelmed, and having some of these additional markers does not always help us, although there are cases where patients are not feeling better, in which case we do need to add secondary testing. So I did order a NeuroQuant brain scan this year on a patient who had an MRI at the neurologist because she was having these seizure-like episodes, and she had a small brain bleed, and she had severe times of brain fog where she wasn't able to remember, where she was, what she was doing. Very scary for someone who was only 34 years old. So for that patient, I did order the NeuroQuant. And what it is it's basically an MRI that is interpreted differently than a typical MRI. So you have to have a radiologist at the place you're ordering it that understands how to interpret it. Next, I do on every patient actually still order vitamin D, both the active 125-di-OH and the 25-hydroxy. So the active vitamin D is often elevated and the storage is very low in patients who are exposed to mold. I have also seen this with Lyme where you're using up your vitamin D very quickly. Remember that vitamin D is really more of a hormone than it is a vitamin, so it's going to act like a hormone. During times of stress, we're going to use it up more quickly. You can also add the HLA genetic testing. I stopped ordering this because both Quest and LabCorp have stopped giving me all the information that I need to actually interpret it correctly, and it is a little bit of a headache. unless you are a geneticist to interpret this correctly. So I have not been ordering this lately. Decide if you need these additional markers that are on Dr. Schumacher's website, Surviving Mold. Alpha MSH can be helpful. I have a little bit more about that later in the presentation. VIP, TGF beta 1, C4A, leptin, MMP9, and VEGF. You can certainly order these and then order them again in 3 to 6 months and just make sure you're making progress. Rule out Lyme, Babesia, Bartonella, Ehrlichiosis, Anaplasma, EBV, CMV, anything that could cause brain fog, fatigue, chronic pain. In children, I typically also am ordering HHV6 ASO to rule out pandas, Coxsackie, and parvovirus B19 if they have joint pain. And this is because, in pediatric patients with mold exposure, they're often much sicker than our adult patients, but they often get better more quickly. Having said that, would be a diagnosis of PANS if they do have mold exposure and they have the symptoms of PANS and not pandas. Pandas would be if they had the positive ASO. Keep in mind, patients can have both. You could have a patient that has an elevated ASO, has an acute autoimmune reaction to strep in the brain, and also has mold exposure. I love Deanna Minnick's detox diet. We do it 2 or 3 times a year in my clinic as a group. It's wonderful because it's just a matter of eating the rainbow. Her wording is very, very positive. She talks all about the foods you are trying to get in, the things that will help you, and her wording does not really talk about restrictions. However, it is gluten and dairy free. So the beginning of the treatment, the first 2 to 3 months of a patient with mold, is actually pretty straightforward. This is where it gets a little bit trickier. Step 5 is to actually reassess the visual contrast test. It is wonderful when you see the patient have a huge improvement on the visual contrast test. If they have not, you need to dig deeper and actually figure out if they've actually removed themselves from the mold. Is it in their car? Are they using a favorite backpack that's filled with mold? I mean, remember, all the porous surfaces can hold the mycotoxins. And then go ahead and rotate binders. You don't need to rotate if they're feeling better and they're tolerating them well. You can rotate the detox support. You can do, Metagenics has a detox cleanse. You can add in liver support, metabolic detox. You can add in a PERC multivitamin if they're low in vitamin E. You can do all sorts of different things to rotate antioxidants and mitochondrial support here. Remember that food sources of prebiotics are going to make a more lasting impact on the gut than a probiotic will, right? The probiotic will help while the patient's taking it, but it really stops helping when you stop taking it within a couple weeks. Whereas leeks, garlic, onion, asparagus, sunchokes, if they can tolerate these foods, they're excellent at reseeding the gut of the good bacteria, the good viruses, the good fungi. We are just starting to learn more about the good viruses and the good fungi that live in the gut, but know that there's a lot we still have to learn. I have moved to using only molecular, 16S RNA testing of the gut. I'm no longer doing stool cultures because they're just not accurate enough. So I'm using microbiome labs for that. Hugely helpful during this step to retest the gut or to test the gut to begin with. And don't forget, we need B vitamins and protein for phase 1 and phase 2 detox, protein especially for phase 2. A lot of patients when they start to eat healthier, they take a lot of protein out of their diet, which is not going to help them detox. And then the next visit with the patient, step 6, is just more supportive care. Take a look at the histamines. You can do cryptopyrroles and histamines with DAO labs. The whole blood histamine is difficult to get with LabCorp. You can do, another allergy panel. You can also do a food allergy panel with US Biotech or Genova, somebody that also adds IgG4 testing for food sensitivities. You can add DAO enzyme. You can also, I already mentioned stool testing. Don't forget about, again, zinc, vitamin B6, copper to zinc ratio, especially if your patients are anxious. I also really do like the Nutri-Eval. I know it's expensive, but I do find that patients that are exposed to mold or mycotoxins or have Lyme are low in isoleucine, glycine, and other amino acids. And giving them an essential amino acid complex doesn't help because we're giving them all the amino acids, and really we need to only be giving them 1 or 2 amino acids. So, personally, after my mold exposure, this was the game changer for me. I finally started to get way better once I replaced the amino acids I was low in, and my isoleucine was really deficient. So you need to have this compounded. I use Village Green up in Bethesda, Maryland. They will compound amino acids for me. They'll also compound multivitamin, which is wonderful, but it is time consuming, and you have to explain to the patient, this follow-up visit is going to be a long one as we go through the Nutri-Eval. You can also look at vitamins A and E, CoQ10, all the Bs, glutathione, heavy metals, omega balance, all in one test. That's why I like the Nutri-Eval. Again, quercetin and nettles, great for allergies. Licorice is wonderful for clearing cortisol, turning cortisol into cortisone, helping with adrenals, as well as gut healing. It helps with patients who have reflux and acid reflux or tend towards constipation. And then don't forget conventional antihistamines. A lot of my mold patients are just going to be on an antihistamine for a long time. Number one, it helps them sleep. Number two, it really helps with this serotonin connection to the brain, and they really need the antihistamines. And it's interesting because they're trying to get off of more of their pharmaceuticals, but most of them need a Benadryl or a Claritin or a Zyrtec, at least for a year after we are healing them from molds. I have a feeling that if you are a functional medicine provider, you already recognize the mind-body connection, but I have to include this step 7, because DNRS, which is the website at the bottom there, Retraining the Brain, has been an essential step to some of my patients going from 70 to 80% better to 100% better. If they had not done this, they would not have completely healed. And I think it's important to also note that some patients might have been starting with a baseline where they really did have baseline anxiety throughout childhood. They had multiple toxin exposures throughout childhood. They had adrenal dysfunction throughout childhood, insomnia, limbic system damage from trauma during childhood. If we ignore that fact, then I think we do our patients a disservice. So I've started asking people a lot of questions about trauma. Once you start asking people about sexual abuse, you're surprised at how many people have been abused. And then, of course, physical and emotional abuse as well. So finding a good therapist, sometimes people like somatic therapy, sometimes people like hypnotherapy, sometimes people do really well with EMDR. But finding a therapist that clicks with the patient can be hugely helpful. If they're turned off by that idea, definitely send them to this website. They can pay for this online program, or they can hire a coach to help with meditation. Part of healing the limbic system, though, is actually doing the chanting or the very quiet, just above a whisper, noise vibration. This is the exercise that will start to heal the limbic system. So a lot of these patients have different reasons why they don't have a voice, and it certainly has affected their ability to heal and to be calm and grounded. They also need to be able to visualize what it looks like to heal. And if you're familiar with Dr. Joe Dispenza, he has a lot of great free YouTube videos. I like to send these to patients in the beginning, reminding them that they have the power to visualize their healing. Okay, so we already talked about setting expectations for at least a year of recovery. Additional detox work can make a huge difference, so I have a handout that just simply lists all the different things they can try. Dry skin brushing, some people love it, some people hate it. It's not that they're supposed to do everything on the list. It's just a matter of finding the thing that works best for them, or the couple things. Epsom salt baths are huge. Castor oil packs on the liver in the evening a few times a week are very helpful, especially for children that have a harder time taking more pills and supplements. Don't forget, phase 1 liver detox requires oxygen. How many times during the day can you stop and take a deep breath? Believe it or not, this may be the thing that helps your patient go from having no pregnenolone to suddenly having pregnenolone, or no testosterone to suddenly having testosterone, or DHEA, same thing. So just remind them to breathe. Remind them that the average American does not take one deep breath a day. So if they can pause, maybe even set an alarm and just do some deep breathing 3 times a day, it will make a huge difference. Okay, so step 9, we're almost there. But this is the part where when patients have not gotten completely better, this is where we really need to dig deeper. I had 3 different patients. I was treating them for Lyme, and they were about 80% better. And then when they found mycotoxins in their home, that was when we actually were able to completely get them better. So, obviously a lot of what we were doing for Lyme with increased magnesium, maybe berber, prunella, and the NutriMedics was helping with mold detox, but it wasn't everything, right? We didn't have them on the binders. We didn't test for Marcons yet. So we need to go back and do those things. They definitely need more limbic system support. If you've gotten them through Lyme treatment and then you find mold, they feel extremely defeated, as anyone would. I've had patients sit in the office just sobbing because they can't believe that they've gotten through Lyme treatment and now they have to deal with mold. But the good news is you have answers, right? If you find mycotoxins in their system or they fail the VCS test, you know that they are dealing with mycotoxins. You know that that's where we need to go next, and you have answers. Whereas at a traditional clinic, if you treated them for Lyme and they were only 80% better, to be honest, they wouldn't know what to do next, right? So I try to remind them of that. Like, I've seen this before. I'm familiar with this. Having said that, I would like to rule mold out first when people come in with a very high Horowitz score, on the questionnaire, on the multi-system questionnaire. I prefer to rule out mold first because I do think it helps to treat the mold illness first, at least for a couple months if they've had persistent Lyme. If it's acute Lyme, that's different. If we know they've contracted it within the last 2-3 months, then I would treat them right away or at the same time as getting rid of the mold. Okay, so this is my case study where I just discussed one of my patients came in with what I would consider somewhat acute Lyme, although I met her 4 months after the tick bite. She was doing yard work. She went to urgent care 7 days later. She had a fever. She did not have a bullseye rash, but she did have CSF drainage from her ears. She was not tested for Lyme at the time. Very strange. They did give her some sort of antibiotic, but it was 14 days. It was not enough to get rid of acute Lyme. Her Western blot was CDC positive, so she had 5 bands. This is one of those ones where you actually get a call from the health department, which is always interesting because I want to say to them, I have said to them on the phone, why don't we talk about all my other patients with Lyme? But they just want to talk about the ones with the 5 bands, right? Okay, and then she had a major adrenal dysfunction. This was before the Lyme. She has a nonverbal 4-year-old with autism, and this child had been up all night since the day she was born. So child wasn't sleeping, mother concomitantly developed adrenal dysfunction. Fortunately, the daughter also became my patient, and we tried a few different things that are helping her sleep, including low-dose naltrexone. However, we have some work to do here because the mom is so depleted of all of her hormones, including her pregnenolone was 0, her DHEA and her cortisol were 0. She has been on hydrocortisone ever since that time simply because she really did have no cortisol. And I was concerned that without cortisol, she would develop an autoimmune disease. So 6 months in, just treating with antibiotics and herbs for Lyme disease. We also tried IV ozone, and that helped a lot. Eventually, though, about 8 to 12 months in, we did find mold in her home, and it was a lot of mold. So they left. They went to go stay with family while the home was remediated. She's doing much better. However, the remediation is like 80% complete, and they're back in the home, which is not what I would recommend, but they simply ran out of money to fix it. They're waiting until October. I have her on binders so that, and she tested positive for Marcons, so we're maintaining her sort of at her stable that way, keeping her stable. However, ideally she would not be back in the home until it was completely clear of mold. And they have been using air scrubbers, which is great. She also has a very good double charcoal filter next to her bed. So doing the best we can, but I am looking forward to when they can completely finish remediating and we can get her better. And then this was just a post I actually did for my class, one of my classes on hormones in school, and I thought I would just post it here, where we talked a lot about alpha MSH and how it basically can influence our leptin levels may also influence VEGF, but VEGF may be completely on its own. Something called the pro-opiomelanocortin pathway, hypothalamus in the brain, is involved here. So if you want to look this up, Dr. Schumacher and Dr. House did a good research study. And there's also this second study that also talks about chronic fatigue syndrome and MSH levels. Just a little bit of extra reading. Not required, but I do think it's helpful to look into some of these additional hormones that Dr. Schumacher likes to test. Again, I think sometimes we don't want to overwhelm the patient by doing everything, but if you're suspicious that their MSH may be either too high or too low, it is nice to test it and then give patient action items for how to fix it. Okay, and then finally, these are my references. There were definitely other websites I included throughout the presentation. Again, survivingmold.com is one of the best websites for the patient. I've also simplified my mold handout for the patient, so if you'd like a copy of that PDF, just let me know. It's written in more patient-friendly language than I think the Surviving Mold website. There's lots of research out there on how mycotoxins make us sick. I hope that this presentation was helpful and that the steps were clear. Let me know as you start to treat patients with mold, or if you already have been, what your experience has been. I think there is power in collective knowledge, and if we all meet or talk about these cases, it would be hugely helpful, and we learn from all of our patients. Thank you so much for what you do, and thank you for the privilege of speaking with you today.